So epidemiology, as all good things on earth, first reports came from the UK, 2004, just a couple of cases showing that there's actually an increase in cases of acute hepatitis C among HIV-positive MSM, linked with recent syphilis infection and not the classic IVDU clientele. Martin Fisher from Brighton then did an analysis in his clinic looking at all HIV patients that had a negative HCV testing available, and he found 25 incident HCV infections among his MSM population. And on a European level, within the Cascade collaboration, 4 methods were used to estimate the incidence, and they were actually able to show that the epidemic probably already started in the mid to end 90s with an increase in cases of acute hepatitis C. So who's infected? Clearly the burden lies with the HIV-positive MSM population. These are pooled data from the UK, France, and Germany, clearly showing that HIV-positive patients are much more likely to contract acute hepatitis C, although you have to give the argument a certain room that HIV-negative patients per se are not in regular medical care, hence acute hepatitis illnesses might just not be picked up. They might just be picked up at some certain time point when they go for routine STD screening. So that's a bias we always have to take into account. So this bar is definitely stable, but the HIV-negative bar is sort of wobbly because we don't know if they experience acute episodes of hepatitis C and they're just not detected, or if this really is the case that the number is very low. Similar data from Germany clearly showing an increase in acute hepatitis C cases, mainly driven by sexual transmission in at least a third of patients. So why is HIV a risk factor to contract hepatitis C? First, hepatitis C RNA can be found in the semen of HIV-positive patients much more often than in the negative ones. Secondly, the HIV-positive patients have a higher likelihood of going to a chronic cause of the hepatitis to not clear spontaneously. And thirdly, and that's sort of reflecting the second point as well, that they have a reduced capability to create certain cellular immune responses to hepatitis C itself, leading to a chronic cause of the infection. So if you really look at the viruses, each virus, slice it up, look at the different parts, you can really see that there are clusters within Europe. So same viruses sort of being transmitted in certain clusters or groups. And these are pictures data from the UK, Netherlands, France, and Germany. And that clearly shows country-specific viruses being transmitted, but also overlapping between the countries, given that Europe itself is a rather small country with very good connections via airlines. So it's probably much cheaper nowadays to go to Berlin over the weekend for partying rather than staying in London and pay a fortune on cab bills and parking, whatever else you have to pay to get out of your house. We use bicycles in Bonn, so I'm allowed to say that. Secondly, if you look at Martin Vogel from our group was actually able to show with contribution from all these countries that the viruses we see in these patients are different from the ones we see in the classic IVDU patients, so the classic injection drug users shown in blue, shown in black, and the colored ones are the other ones. So there's clearly different viral strains that are being transmitted. Axel Schmidt quite a while ago issued questionnaires because the interest rather soon grew. Why is it? Why do get patients acute hepatitis C episodes? And he set up a questionnaire that was handed out anonymously to the patient, and they had to fill it out and send it to our National Health Institute, the Robert Koch Institute. And via a rather complicated analysis, he was able to show that mucosal trauma with bleeding and consumption of nasally administered drugs were statistically, maybe not in life, but at least statistically associated with acquisition of an episode of acute hepatitis C. So this is the picture we are currently facing. It's actually a global epidemic. Europe started with first cases, Australia followed, then cases from the US, and recently we've reported cases from Canada, a couple from Taiwan, and even one from Lebanon that sort of made it through the censorship, whatever is in place. So really a global epidemic, still growing, and I tried to find something on Hungary and just found a publication online that's already from 2008 or 9, which unfortunately shows no data, so there weren't any data available to be included into the analysis. And secondly, I then looked at the ECDC reporting, and this is the part from Hungary. It's a 100-page document. Each country gets almost a page. So the targeted population for HCV screening programs are just classic injection drug users and workers, so healthcare workers, and all the other populations, especially the ones with multiple sex partners and STD clinic patients, the patients where we expect the burden of acute hepatitis C to lie, are definitely not part currently of any screening programs, and this will probably explain why we don't have any numbers to talk about today, at least for Hungary. And if you look at the ECDC reporting system itself, you already get a good picture of why this is so, because most of the reporting is done passively. So they have to be asked to report their numbers, and they are mostly reported by laboratory and physician, and to a lesser extent from hospitals. So the problem really is that the reporting of acute hepatitis C episodes is varying. Then there's no consistent definition what is acute and when it turns into chronic. Mostly data on HIV status are not collected, and data on sexual orientation neither, and that makes it rather complicated to get at least an idea if the epidemic is going on in Hungary or not. So when is an hepatitis C actually acute? The problem arising with that brought experts together in, I think, 2010 it was, in May in Paris, and they sat together and collected all the data we have. Most of them are from cohorts, just to get an idea and give some recommendations for the clinical management, how to deal with patients. And the definition of acute hepatitis C would be in positive antibodies and or positive HCV RNA, and you need to have documented negative antibody status within the previous 12 months. Or if you've got a positive HCV RNA, you need a documented HCV RNA negative and negative antibodies. If you don't have, because that happens quite often that patients show up at your office for the first time, you don't have data from previous visits, there's also an algorithm in the guidelines which I didn't show, that you can base your diagnosis of acute hepatitis C on the ALT values with respect to the previous ones. So the problem really with the HIV positive patients is that they tend to have lesser elevated liver enzymes when you compare them to HIV negative ones, so it's just a third. Plus, they are much more likely to not show any signs and symptoms of an acute hepatic illness, so 32% versus almost 60% in the HIV negative ones. So the disease is rather easy to be missed, especially in HIV positive patients. Second problem is that the development of antibodies, as with every illness in the setting of HIV, can be delayed, and we still have this fantastic data from Emma Thompson. We still have 5% of patients that still have seroconverted after 1 year of their infection. Almost all of them have converted after 6 months, but there's still some patients who might not be anti-HCV positive after 12 months. So if you really suspect an acute hepatitis C to be going on, you really need to do the PCR and look for the HCV RNA. And this is very much in line, so around 15% of patients, it's a bit varying depending on which cohort you look at, if it's an epidemiological cohort or a treatment-focused cohort, but around 15 to 20% spontaneously clear the acute hepatitis C infection, and prognostic factors are high CD4 cell count, low hepatitis C RNA, and certain negative HCV RNAs throughout the course of the disease. But still, and those are data from 2007 from the European Collaborative, there's still some fluctuation. So patients who are negative with their hepatitis C 12 weeks after the diagnosis, a small number of them can be detectable at week 24, and of those being detectable, they can go negative. So there's a certain way of fluctuation, and that just means you have to really follow up your patients, which means a negative HCV RNA 12 months after diagnosis doesn't mean 100% that the patient is cleared. You really have to remeasure the hepatitis C RNA in the following month. So do we have data on which we can base our decision if we want to treat or not? Yes, we sort of have cohort data. So we know from the monoinfected patients that if you wait for 12 weeks, there's still high response rates, but this is in monoinfected hepatitis C patients. And the ones with the genotype 1 and high HCV RNA have a worse outcome. And the early cohort data from France and Germany showed that there's actually no influence on treatment outcome regardless when you start the treatment. But there were newer data presented from Katja Deterding from Hanover showing that the patients who are symptomatic and undergo deferred therapy have a worse outcome than the ones who are put on immediate therapy. That's monoinfection again. And secondly, Martin Vogel was able to show that the patients who experience a negative hepatitis C RNA at week 4 are most likely to clear, and the ones who don't are most likely to progress to chronic infection. And that means that week 4 really at the moment is our cutoff to not decide, but at least recommend against or for treatment. So if the patient has shown a more than 2 log decay in his HCV viral load, you can still monitor him up until week 8. If there's a further decay, you wait until week 12. If he's negative, then he is cleared. If he doesn't show the 2 log decrease at week 4 already after the diagnosis, he should be at least recommended to start treatment. The same at week 8 and the same at week 12. Before you start treatment, that's the standard you have to do when you treat chronic infection as well. There's no difference. I just wanted to point out because that's still in the guidelines, and a number of physicians in Germany tend to not do it. You have to measure autoantibodies and especially the thyroid function before you start treatment, just to not miss an autoimmune thyroiditis before you start treatment with interferon. What is the current therapy of acute hepatitis C? Now that everyone is talking about protease inhibitors, the current gold standard still is pegylated interferon and ribavirin for all genotypes. And if we do that, these are a couple of cohorts showing the outcome, we can see very high response rates, 60 to 80%. That's much higher than the rates we see in chronic infection, almost at least double the rates we see. So the treatment in the early phase is very, very successful. So the patients who experience a negative HCV RNA at week 4 will have an SVR in 93% of cases, and the ones who are negative at week 12 will, in 85% of cases, have a successful treatment outcome. So again, we have to measure the virus 4 and 12 months after the start of treatment to get an idea how the outcome of the infection will be, and that results in an algorithm tree that's sort of similar to the ones we've seen in chronic infection, but on this slide, the duration of treatment is a bit short and different because it's in the setting of an acute infection. So you reassess your patient in week 4 and look if the hepatitis C is still detectable or not. If it's not detectable, you measure again at week 12. If it's below detection, regardless of the genotype, that's the difference to the chronic infection, they are treated for half a year, 24 weeks. If HCV RNA is still detectable at week 4, you reassess them again at week 12. If you've got a more than 2 log drop, they are treated for 48 weeks, regardless if it's genotype 1, 4, 2, or 3. And that's also different to the chronic hepatitis C setting. If there's no drop more than 2 log at week 12, you can discuss with the patient to stop therapy because the likelihood of achieving an SVR is very, very low, and he will just be coping with the side effects of a therapy that very likely won't work in the end. What do we have to do throughout treatment? I just put it up here again. That's very, very similar to the assessments you have to do in treatment of chronic infection. You need to measure the thyroid function every 3 months, apart from the HIV and HCV parameters. Then you could talk about factors that might influence therapy outcome. Alison already talked about IL-28B, which plays a major role in the chronic hepatitis C infection, and the question is very close to ask if it does play a role in the acute infection as well, and the short answer for the moment is no. So IL-28B just higher your susceptibility to interferon, and the idea is that in the setting of an acute inflammation, the susceptibility is already high enough that the IL-28B polymorphism doesn't play a major role anymore. And that's backed by data from Emma Thompson and from Jakob Nattermann from our clinic, who was clearly able to show that there's no statistically significant difference in reaching an SVR if you treat acutely infected patients, regardless if they've got the favorable or the non-favorable hepatitis C IL-28B genotype. The second question would then be, because we know that the treatment responses are different with respect to the underlying hepatitis C genotype in the chronic setting. So the question is very well, does the same apply to the acute setting? Are the patients with the genotype 1-4 infection responding poorly compared to the ones with the genotype 2 and 3 infection? And yes, this seems to be the case. So far, this is an analysis from 238 acutely hepatitis C infected patients throughout Europe from multiple centers. Again, no randomized controlled trial, just cohort data, and that clearly shows you favorable SVR for the patient with genotype 2-3 infection compared to genotype 1-4 infection, although it's close to borderline. But it seems to be the case that patients with genotype 2-3 respond better to the classic standard therapy than the ones with 1-4. And that's, again, statistically significant in multivariate analysis. So the second question that also is still under discussion, is ribavirin still useful, remembering that interferon monotherapy is valid for treatment in hepatitis C monoinfection, and the mechanism of ribavirin are still under discussion, still not understood, at least not by me, so I won't dwell on this slide because I just lack the intellectual capacity to. So at some points, the proposed mechanisms and points of interaction with ribavirin might enhance and might have some antiviral activity. What we do know is that ribavirin improves the hepatitis C RNA decay kinetics. That means early on, if you add ribavirin, the HIV RNA goes down much faster than if you don't add ribavirin. This is backed up by data in a sort of clinical trial that just shows you the only thing that was really important was reaching an RVR to get an SVR, and that was regardless if the ribavirin was taken off at week 8 or not. So the crucial part, the crucial role of ribavirin seems to be within the first weeks or month of the therapy and not on the long run. That, on the other hand, means that you can discuss with the patient if he's suffering from severe anemia to decrease the ribavirin dose once you've passed week 8 or week 12. And then one small analysis, unfortunately, from our cohort, Martin was even able to show that patients with no ribavirin were actually much better off than the ones with combination therapy, but this was luckily enough not statistically significant, so we'll just leave that as an anecdotal note for the moment. So the discussion is still ongoing. Do we really need ribavirin, and what about treatment durations? Are 48 weeks better compared to 24 weeks? We had a look at our cohort again. This time we were able to include 303 patients, although we had a very low number of patients with a genotype 2-3 infection, because most of these viruses are transmitted within classic standard IVDUs, and most of our patients are MSM, and they tend to acquire genotype 1 and 4. We saw that if you look at the whole patient population, there's no difference in SVR rates, regardless if they got ribavirin or didn't. And then, taking into account our previous findings, we had looked at genotypes separately. So in genotype 1-4, it doesn't seem to make a difference if you use dual therapy or just mono interferon therapy. But if you look at genotype 2-3, there was a difference. So the genotype 2-3 patients tend to respond better if they get added ribavirin to the interferon therapy. Like syphilis, we are able to treat hepatitis C, but patients might get reinfected, especially if the risk factors sort of remain stable, and this is what we have to tell our patients and counsel them. The therapy is quite hard. They really have to fight themselves through, and you just have to tell them, look, the virus is gone now, but you might be in a situation where you can reacquire the hepatitis C, and then we have to redo the whole treatment course. So is reinfection an issue? Yes, it is. Again, first data from the UK, 22 patients, and they were clearly able to show that there are new episodes of hepatitis C after the first episode was over. Fresher data from the Netherlands, they've got 56 co-infected MSM and 5 relapsed, and 11 got reinfected with different genotypes, and that leads to cumulative incidence of 3% within 2 years. And again, the ALT level during follow-up seemed to be the best sensitive marker to pick up a reinfection with hepatitis C. The freshest data come from Berlin, of course. That's where you would go if you want to get an acute hepatitis C. 45 MSM patients, data from Patrick shown at CROI this year. 5 spontaneously cleared, 40 were treated successfully, and I just wanted to show that there's even one patient who got 4 episodes of an acute hepatitis C. And interestingly enough, that's where all the lab people probably get very excited. He was able to spontaneously clear each episode. And if you could always argument that it might just be a relapse. No, in most of the cases, there's been a genotype or at least a subclade switch. It's really a new virus that has sort of found its way into the patient. One of the last issues that are currently under discussion is liver fibrosis, not only in chronic infection but also in acute hepatitis C. The data are very sparse, and the FibroScan reading, this is what everyone does at the moment, are not very liable because the elasticity of the liver changes under the acute inflammation, and no one really knows if the elevated values we are seeing in FibroScan are really reflecting a chronic liver damage or if it's just reflecting the acute inflammation of the liver. And Martin Vogel from our group was able to show that over a longer term, it's not long term, but longer term, up to at least 6 months, was able to show that the values go down again with the FibroScan, showing that there's sort of, with the spontaneous clearance or at least going to chronicity of the infection, the liver elasticity recovers, sort of easing physicians that argument we have to treat the acute episode because the damage to the liver is too high. This is a bit in contradiction to the data from the US. They are much more liver biopsy based, and they tend to see higher grades of fibrosis, but they lack the long-term follow-up. Last one, as usual, is a promotional slide. No leaflet this time, but just a slide. So we've set up a cohort to cover all acute episodes of hepatitis C in HIV-positive MSM, but also HIV-negative MSM, and are very open to any contributions, preferentially via email. It's not a trial, so there won't be any medication, there won't be no recommendations for the treatment agents you have to see, but we would just like to collect the data to really get a clear picture throughout Europe, especially Eastern Europe, if the epidemic is still ongoing, who clears, who gets a new infection, etc. Thank you.